right, well, it is now noon. I want to go ahead and get started because I'm pretty sure our speaker's got a lot of information to share with everybody. I hope you can hear me, and welcome to everybody today. This is September 20th, 2018 Lunch and Learn webinar. I'm Jerry Newman, your Northeast NEFHIMA president, and we are excited to be able to continue to offer these webinars to our members and to our students. Today's webinar has been a collaborative effort with Northwest and with Ocean, so we welcome them as well to our meeting. If you're not a Northeast NEFHIMA member, we'd love to have you join us as a member. Current membership signups are valid through June 30th of 2019, and all webinars are included free to active and student members. Just a few housekeeping rules. Please mute your phone and don't place your phone calls on hold, especially if you have hold music. If you are only signed into the phone part of the webinar, please be sure to email me to let me know that you attended, since your name does not always appear via phone dial-in. Handouts were sent out via email prior to the meeting this morning, and a CE eval and form will be sent out a couple of days post-meeting. And lastly, if you have any questions during the webinar, please feel free to type your questions into the text box or into the chat box, and we can address your questions during the Q&A session. So on that note, we really have been kind of fanning out, and I'm very grateful to Tom Mary, who is president of Alliance 10 out of South Florida. He is a volunteer on the FEHIMA Marketing Committee and a proud supporter of the FEHIMA Regional Association. Alliance 10 was created to provide services and solutions to help information management, privacy, security, and revenue cycle professionals. And by choosing only companies that fit Alliance 10 standards for service quality and citizenship, they're proud to make introductions and create new alliances for their valued customers and business partners. Business partners include Compliance Pro Solutions, Tim Cloud, AdLumen, and a company that is presenting today, FairCode. So, Tom, I'll turn it over to you.
Thanks so much, Jerry. Hello, everybody. Everybody's doing well. Before I introduce Martha, I want to make a quick little commercial. FairCode will be at NEFHIMA, so anyone that's going to be attending NEFHIMA, stop by booth 1248. We'd love to see you there. And with that, I'll get started. We're real excited. FairCode is a fantastic business partner of mine, so I'm real proud to present Martha Lamplety. She's going to be talking on CDI and kind of the evolution. I won't steal her thunder. But Martha is a graduate of the University of Tennessee Center for Health Sciences, and she's held various progressive leadership roles within the health information management space, hospital administration, as well as provided consulting services and long-term facilities. She led an organization through a migration from the paper medical record to an EMR, as well as the installation of other hospital information systems. From 2007 to 2015, she was the Chief Revenue Cycle Officer at Nashville General Hospital, where she provided administrative oversight of patient access, patient accounts, health information management, case management, and social services. So her arms were quite full. In fact, in that role, she was actually a customer of FairCode, and that's kind of how she came about to being with FairCode. And currently, she's serving in the capacity of Chief Operations Officer for FairCode. And since she's kind of sat in the seat of many of you on the call, has great insight into what it means and how FairCode can really help you all. But today she'll be talking about CDI. And with that, I will turn it over to you, Martha. Thanks so much for participating today.
Yeah, absolutely. And thanks for inviting me. I also will be at AHIMA, and I'll be hanging out with Tom some in the booth. So certainly drop back by and visit us if you can. I'd love to be able to meet all of you in person. That's one thing about doing something remotely like this using technology, is I miss seeing everybody's faces and shaking your hands and getting to know other people in the industry. But sometimes it is a great thing to do because it allows a lot more people to participate in today's work environment. So welcome to everyone, and we'll go ahead and get started. One thing we all know as healthcare professionals is that change is inevitable, and CDI has not been immune to these changes. The number of external factors that drive us to continually reshape and restructure our departments and programs just continues to grow. Today, I'd like to explore the evolution of CDI and how that's causing us to rethink how we deploy our resources. The first CDI programs were definitely financially focused. Our goals were to establish working DRGs to help our case managers impact length of stay. Those shorter stays, of course, were supposed to increase profits. To do that, we needed to assure that all of the CCs and MCCs were documented during the patient's stay, and in theory, the steps would improve the hospital CMI and reduce their DNFB because those queries would have been initiated and answered before the case made its way all the way to the coder. Then APRs came along, and assuring that risk of mortality and severity of illness were captured properly also impacted our reimbursement. And of course, yes, guess who was tasked with that? The HIM and CDI teams. You got one more thing to do. As healthcare reimbursement began to change, CDI programs began to see scope creep, and adding in quality initiatives to their list of responsibilities as a result of POA assignment, hospital-acquired conditions, patient safety indicators, value-based purchasing initiatives, readmission reduction programs, and now the newest thing on the horizon, outpatient CDI programs. The Patient Protection and Affordable Care Act began to tie the reimbursement to quality, and that act had very lofty goals. Supposedly, this particular piece of legislation had a triple aim. They wanted it to drive better care, healthier people, healthier communities, and the biggest goal of all, affordable care. Compliance with the ACA brought programs like your hospital value-based purchasing program, again, the readmission reduction program, and HACS, the hospital acquired condition reduction program. And each one of these programs brought with it specific documentation requirements and monitoring requirements. Hospital CEOs and CFOs and quality directors began to realize the far-reaching impact that the programs were going to have, and they began to sit up and pay attention to the work that your team is engaged in every day. And just like everything else in healthcare, all these measures continue to change and evolve over time. The core measures, I'm sure everyone in the room knows about the core measures because they've been around for a while, are national standards of care and treatment for common conditions. And in 2003, you'll probably remember that the core measure data began to be collected and reported in the hospital compared data and as a part of the hospital inpatient quality program. The purpose was to reduce complications and lead to better patient outcomes. And it resulted, hopefully, in a decrease in the cost of care. Patient safety indicators were another set of measures, or you may be familiar with them as PSIs, and they were created by the Agency for Healthcare Research and Quality in 2003. And a subset of these indicators now have been included in the composite measure impacting performance under the hospital value-based purchasing program. ICD-10 codes determine which cases flag under these initiatives, and many of you may have learned about this program the hard way, the way I did back in 2003 when my quality director showed up at my door and said, surely to goodness, you have coded these incorrectly because we are flagging outside the norm on all of these areas. At that point, I began to have to dig in and learn a lot more about patient safety indicators and learn what was driving them so that we could proactively monitor and assure that we were coding correctly. In my organization, I think we found that, most likely they were coded correctly. A lot of it had to do with the quality departments not necessarily understanding the coding guidelines and not understanding what actually caused cases to flag. Data initially through these programs was abstracted manually by your quality department, sometimes the HIM department. And with the implementation of EMRs, more of the data now is being collected through analytics. Back in that day and time, your HIM departments and quality departments really rarely interacted. But now they have to work together because so many of our metrics are driven by coded data. So building an alliance with your quality department allows each of you to bring your expertise to the table and learn from each other. So if you don't have a strong alliance with your quality department, I would encourage you to do so. So our methods have continued to evolve, and CMS is moving us towards claims data to collect the indicators. Under value-based purchasing, core measures classified under the process domain contributed to 70% of the score in 2013. In 2018, the process domain was eliminated and only one abstraction measure remains. This has significantly reduced the burden on the hospital and again has placed a lot of focus on our coding teams and placing our profession in the forefront with the responsibility to educate others on coding guidelines. Value-based purchasing intent was to reward the higher performing hospitals with incentive payments and penalize the lower performing hospitals. This, of course, is the potential for loss, which very few hospitals can afford. And the make or break situation calls for innovations by hospitals using alternative measures and programs to assure accurate reimbursement. The hospital value-based purchasing programs implement a pay-for-performance approach. And these programs account for the largest share of Medicare spending and affect payments for inpatient stays across approximately 3,000 hospitals across the country. Under value-based purchasing, your hospital is assessed either on how well they perform compared to other hospitals or how much they've improved compared to the baseline period. Many times we don't begin watching a measure until after the baseline period has already been established. And when this happens, we don't have an ability to assure that the data in the baseline period is accurate. CMS is assuming, of course, that all of our claims data is accurate, and they make reimbursement changes and program changes based on that data. This tells me that we have to be thankful for our HIM professionals who are trained in coding. And they're sticklers for consistency and accuracy, and that's what makes this work. Their coding expertise is driving much of the data that you're compared to, and forging those relationships that I mentioned earlier with your quality departments, helping them understand those rules will help make you all better at what you do and make leadership have a better understanding of the outcome. Value-based purchasing measures are grouped into specific quality domains, and they're going to vary from year to year. In 2017, the domains included clinical processes of care, patient experience, and you'll remember those surveys from our patients, and that was included patient outcomes, efficiency, patient safety through the use of achievement thresholds and benchmarks. As measures prove to no longer be effective in measuring and facilitating change, they're retired. And in 2018, this has been reduced to 4 domains. Each of these domains is now equally weighted at 25%. And those current domains are safety, clinical care, efficiency and cost reduction, patient and caregiver-centered experience of care, and care coordination. So I'm sure everybody in the room today can agree that, of course, quality matters, not only to our patients, but now to CMS and to our hospitals. 30% of Medicare reimbursement is now associated with quality, and this is only going to grow. Our results are publicly reported through Hospital Compare, Leapfrog, Healthgrade, Vizient, and the consumers now really have real information in front of them. Even though that data may not be up to date, they are using that data to make choices in their providers. Well, what will the future bring? Who knows? But the recent developments with Berkshire Hathaway and Amazon certainly make for an interesting future. How will their entry into the healthcare market impact our selection of providers? Amazon tells us, I think, that 35% of their revenue is generated by their recommendation engine. You know, how many times have you clicked to buy something on Amazon simply because it came up as a recommended item? What's going to happen if they recommend a provider in your local area with a low complication rate or lower fees? Will you choose them based on what Amazon puts in front of you? How will your consumers evaluate the quality of care? What reporting mechanisms are going to be used? Well, no one knows for sure how all this is going to be playing out, but making sure our documentation accurately reflects the severity and complexity of our patients' conditions, and that the conditions are coded and recorded accurately on our claims, will continue to influence our payments and now more than ever influence our consumers' choices. So where do we go from here? How do we get our arms around developing a program that's going to meet everyone's needs? ACDIS has suggested best practice strategies for CDI departments as they begin to establish direction and leverage the strengths of their staff. ACDIS forecasts that the focus of our CDI programs are going to shift from quality as opposed to reimbursement. And I know that many of my clients at FairCode now are validating that this is actually happening in their hospitals. You may be seeing it happen in yours. They tell us in their best practice strategies that we first need to collaborate. Don't duplicate the work of other departments. Your CDI and your quality, your HIM, your coding, is your CDI team and coding team querying for the same things? Are your CDI and quality teams looking at the same elements that your coding teams are? Items which can't impact change, are they abstracting and reporting data, or does it match your final coded data? Where should those functions really occur? The same way you only want one place in the record to document a specific element, you also want to make sure that the work is only performed one time by one area, eliminating that duplication of effort and improving the validity of the information. The second thing they tell us to do is to identify root causes of performance issues. If the report reflects a quality problem, you need to dig in. Your coded data may not accurately reflect the clinical scenario, even when the case is coded accurately. Data is extremely important, but understanding how to interpret it is going to be key to the success of your program. Sometimes we can jump to a conclusion without really studying the data. There can be multiple reasons for an outcome, and we have to look at that data carefully to really discern which thing is actually driving the result that we have a concern about. The next thing they ask us to do is differentiate. Parse out what's truly a clinical documentation issue versus a clinical process issue versus a coding issue. Each of these require different types of solutions. So if your perception is that you have a coding issue when actually it's a documentation issue, you would implement the wrong solution. And then the fourth thing they tell us to do is to consider varying your sources of data. An example of that could be your infection control data that's submitted to the CDC. In your hospital, how is that captured? And does it match documentation and coding? Most likely, it's reported off of culture results directly from the lab. Well, theoretically, that should match your physician documentation and your coding on the account. But what if it doesn't? What if there are data discrepancies? Which data is correct? And how do you make decisions? Which data do you look at? What are others seeing? It's very important to test that and make sure that your data is consistent throughout your organization. So how do you proceed in this new environment? Well, your CDI teams can either identify the cases for the quality department and continue their focus just as they always have, or they can conduct the reviews themselves and identify the cases and validate inclusion and exclusion through the clinical validation process. A 2016 survey of CDI programs reflected the beginning of the movement into the area of quality. More and more changes in healthcare reimbursement have continued to drive the percentages up even further. And in 2016, this survey reported that 64% of our programs were already focused on making sure the documentation accurately reflected severity of illness and risk of mortality. 56% were already monitoring for documentation for hacks, and 49% in 2016 were already looking at PSI. And as we discussed earlier, our documentation is being used not only for the medical coding and reimbursement, but also to gauge the quality of care that's provided. ACOs, or your accountable care organizations, and healthcare mergers and acquisitions are on the rise. You probably hear about those and read about them in the news all the time. And it's causing hospitals and health systems to look for ways to expand their CDI efforts into the outpatient arena, into ambulatory and physician practice settings. The regulatory changes around bundled payments incentivize efficient and effective care, and they're requiring physicians to document as specifically and completely as possible. Public outcome data has caused our physicians to take notice of their coded data and question its accuracy. But because historically our physician reimbursement has been based on CPT codes, the accuracy of the ICD-10 codes many times was of little importance to them. And many physician offices, as you know, haven't hired certified coders. And those codes are selected from a super bill, and typically those codes have very limited specificity. The Physician Quality Reporting System and the EHR incentive programs both have pushed that physician to do a better job. And as HCCs and bundled payments begin to impact reimbursement, many CDI programs are now moving into the outpatient arena. Our CFOs have begun to question, my census is up, my patient satisfaction is high, patient outcomes are favorable. Why is my revenue declining? Well, there can be many reasons for that. Your procedures may have moved from inpatient only to the outpatient, and that's going to result in a higher CMI on decreasing volumes in your hospital. You could be underreporting your HCC, and that can create an impression that the hospital is not providing a high quality of care on paper. And it may seem to be that those patients are actually healthier than they really are if you're not capturing the HCCs properly. If you're over-reporting them, it can also attract increased scrutiny by CMS and lead to potential recoupment of overpayments, and then create an inflated prediction of costs. So lots of different reasons. So why is this important? Well, your HCCs impact the amount of funding the Medicare Advantage plans receive per patient from CMS. And then this is passed along to the providers. And in Medicare Advantage plans in 2017, 33% of our Medicare beneficiaries were enrolled in Medicare Advantage plans, and that's only going to continue to rise. The development of outpatient CDI programs is very young, and you may or may not be hearing a buzz about it in your organization. We're just beginning to see literature published outlining successes and failures of the programs from some of these pioneers that have stepped out there and already are implementing them. In 2016, only 10% of hospitals had outpatient CDI programs, and then in 2017, I think that rose to about 20%. And it's continuing to rise. Some places you might see outpatient CDI programs pop up in your organization could be the emergency room, observation services, outpatient diagnostic and surgery, your HCC captures, ambulatory clinics, home health, and hospice. So how do you get started if you want to develop an outpatient CDI program? Well, some of the things you could do is first identify volume of denials for incorrect status. And as far as I know, I think that's something every hospital still struggles with. But once you have a baseline, you can measure your improvements. And if this is considered an area of risk for your organization, that might be something you want to focus on. You could also identify volumes of outpatient medical necessity denials for outpatient surgical cases. Develop programs that are going to target documentation requirements for the procedures which are most commonly denied. Because physician offices are many times obtaining authorization for procedures with the carrier, the code they authorize is many times not the final code that is on the claim, and it results in a denial. I know I struggled with that constantly in the hospital, and we were very frequently trying to put in stopgap measures to try to prevent that from happening. But that clerk in the physician's office takes a code from a super bill, and they off it. Then when the patient actually gets to surgery, the actual surgery done doesn't match the actual code which was authorized, and therefore there's a denial. If your organization is an ACO with physician practices participating in Medicare Advantage plans, targeting that documentation for relevant HCCs could also be important. The biggest issue is that the list of items that you could be monitoring just gets longer and longer. And your biggest challenge is going to be to establish a focus, just like it was on the inpatient side. And as you try to staff the programs, we have to remember that a good patient clinical documentation specialist just doesn't equate to a good outpatient clinical documentation specialist, because you have to teach them the outpatient reimbursement system. They're going to need to understand OPPS, APC, HCPCS codes, status indicators, their EMM levels, Two-Midnight Rule, and of course the value-based purchasing indicators. And many of these things are not things that your inpatient CDS actually are schooled on. And you may keep hearing the term risk adjustment. This is a method of payment where prior year information is used to predict next year's cost. The results of payment adjustments from CMS to Medicare Advantage plans, and the factors included in the risk adjustment it would be age, gender, socioeconomic status, disability status, insurance status, diagnoses codes, place of service codes, and specific conditions such as ESRD. The hierarchical conditions that are used to categorize the multiple levels of severity of diseases, and the payments are made on the most severe manifestation of the disease. And if we don't capture those chronic conditions annually, then what happens in the data? Suddenly, limbs grow back on amputees, previously paralyzed individuals walk, diabetics are cured. The codes for these chronic conditions have to be captured annually, and you begin to capture them every year, January the 1st. It starts over. In order for diagnoses to be utilized in this process, it has to be captured either in the hospital inpatient or outpatient record. It has to be captured at the time of a face-to-face office visit, and RN visits only don't count. The physician diagnoses, regardless of the setting, the physician has to indicate the diagnoses. It can be done in an ICF, an SNF, a dialysis facility, as long as it's during that face-to-face encounter and the physician is there. The diagnoses can be made by other clinically trained non-physician providers, such as psychologists, podiatrists, nurse practitioners, and physician assistants. But when they do document it, the documentation has to be for a current problem on the day of service. It must meet coding guidelines to be picked up in coding, of course, and it has to be signed with identifiable credentials such as MD or NP. And some of the most commonly missed HCCs that fail to be documented include hepatitis B and C. It's got to be documented as chronic or resolved. Drug and alcohol dependence or recent tobacco use or dependency, many times is not picked up and it needs to be. Diabetes mellitus with complications or uncontrolled. Major depression, you need to know the frequency and severity. Is it major depressive disorder versus depression not otherwise specified? Very important to know the difference and get that documented. Cancers that are coded as history of instead of active. And peripheral neuropathy, knowing what that is secondary to. Old myocardial infarction, renal failure, insufficiency or low GFR, malnutrition associated with involuntary weight loss, and morbid obesity. So some of the challenges in developing the outpatient CDI program is that you have high volumes and quick turnaround. So it's very challenging to have FTEs and enough FTEs to look at that real-time documentation and be able to make a difference. So just like in that inpatient program, you've got to establish a clear vision and a clear focus so as not to be fragmented. You've got to have buy-in from leadership. That's going to be critical. You've got to keep them engaged in the discussions and keep them informed of your progress. Hold fast. With limited staffing, you just don't want to be tempted to mesh your case management programs and your programs. They just have a different focus. I know when I was in the hospital and CDI programs first began to develop, my hospital, along with many other hospitals, attempted to do that without additional FTEs, and obviously the approach was not successful and we had to change direction. So what will you gain from an outpatient CDI program? Well, depending on your selected focus, you could see improvements in physician documentation as far as it reflecting that physician's clinical judgment, the physician's medical decision-making process could be improved in the documentation where they're actually outlining why they believe that particular diagnosis is evident. Because many times as we do clinical validation, all the indicators may not be met, but that's where the real physician and the real diagnosing takes place, and the physician needs to document that medical decision-making process and his clinical judgment in the record. And you also may see improvements in the acuity of the patient level by improving that documentation. You could achieve improvements in the assignment of patient statuses and improvement in documentation and supporting those observation services, which probably is challenging for many of you, such as the EMM level assignment and the charges for injection and infusion, start and stop time, accurate problem list, improved capture rate for POA indicators. It's just difficult to be everything to everyone. And the question becomes, can you do it all? Funding a CDI program that meets everyone's need is just likely impossible in most healthcare organizations. So where will you focus? What will your vision be? Will it be quality, financial, compliance, legal, payer contracting? In trying to decide what's best for your hospital, you want to consider leveraging the strengths of your CDI team. A clinical documentation specialist is in the chart real time. So you want to focus your program on elements that require concurrent review, which can't be managed retrospectively. You want to save those tasks for others. Your staff are also very, very seasoned professionals with years of clinical experience usually. So you want them to focus on elements that require skill and expertise. Don't let them become data abstractors, which I have seen occur. Target specific areas of focus to prevent the program from becoming fragmented. Remember, your clinical documentation specialists have collaborated with medical staff all of their professional careers. They're very comfortable having those clinical discussions. So remaining focused on a strategy that uses this experience and assuming responsibilities in your program that require interaction with the medical staff. Your next step is you're going to have to develop some key performance indicators so that you can measure the success of your program, and that's going to be critical. Technology will play a key role to assure data is collected consistently and eliminate potential human error for calculations. You've got to define your indicators, you've got to establish your baseline, determine what your benchmarks are, set your goals, and then track your work effort and your results. I do caution you when developing your measures. We're all human and we like to succeed, and so sometimes inadvertently our measures can change the behavior of our staff inappropriately. If you measure staff by their query rate, you may drive up the number of inappropriate queries so they can meet the target. If you measure your staff on the number of accepted queries, then the staff may be less likely to query unless they're sure they're going to get a positive response, and perhaps avoid querying certain physicians. If you do decide to use these measures, make sure you take the possible human factor into consideration. And if you plan to use this to gauge individual success or success of the program, you have to be very careful how you use it. Learn how to interpret your data that you collect. Many times, again, as we mentioned before, there can be multiple explanations for outcomes, and if the data is not interpreted correctly, the wrong decisions can be made. Make sure you've trained your staff so they're prepared to be successful in their expanded roles. You have a lot of resources at your fingertips within your hospitals that can be leveraged at no additional cost to the organization. Use your quality department, your case management department, medical staff grand rounds, local consensus statements, physician advisors. Target these people within your hospital to help with your training. Consider developing a career ladder for your staff to improve recruitment and retention. A good clinical documentation specialist can be very, very hard to find and very expensive to grow. Literature suggests, and feedback from my clients tell me that it can take a full year for a new CDS to become effective in their job, and that's really a huge investment if you think about training somebody for a whole year before they're really good at their job. Stay tuned to changes and modify your program when better opportunities occur. This could just mean new ideas or possibly a leadership change. You want to work strategically and take advantage of the situations to improve your program. Do you think you need additional FTEs to implement these programs? Do you think that's even going to be possible? Because requesting an FTE at budget time can be a very painful and unsuccessful experience that most of the directors in the room are probably very familiar with. You want to be sure to consider the strengths of those in your other department and include that in your model and vision. Make sure you have your tasks appropriately assigned to the correct area and the correct department. Look at quality, look at case management, look at coding, look at look at finance. Return and look at those ACDIS best practices that we discussed a little bit earlier in this presentation and determine really where should each piece of the puzzle reside. Identify skills that can be taught to help others in their new roles, because as you begin to develop your program and you shift responsibilities around within your organization, you're going to need to train those individuals and help them be successful. Think about how can your coding team help the quality team and the CDI teams learn more about coding, and how can your quality teams and CDI teams help the coding team learn more about medicine, or more about which codes trigger PSIs. And make sure leadership defines the roles for each group. So as you develop this program, having leadership at the table and involved with buy-in on what the quality department's going to do, what the case management department's going to do, what the HIM department's going to do, And what the CDI department is going to do is going to be of great importance. Otherwise, proving your success is just going to be an uphill battle if they're not involved in identifying the metrics to measure you. You can't just sit in your office and come up with those measurements if they've not bought into them and understand how they're calculated. When you report that data out, it's going to be questioned, and there may not be a clear success identified. Partner with external resources is another option to fill in gaps that may be left as a result of the shift from financial to quality. There's some things that can just be better done by others, and leaving your staff to focus on things that they can impact in real time. I know when I was in the hospital, I took the opportunity to outsource several different things because it just made sense. And sometimes it was technology because I didn't have the technology to do it well. Sometimes it was recruitment and staffing where I just had a hard time holding on to skilled people in certain areas. A lot of different reasons. Sometimes an external vendor can just do something more efficiently because they do it over and over and over again, and they're not pulled in every direction like you are when you're in the hospital every day. Again, some of the things that you might consider outsourcing that are probably some of those I already discussed. You know, how many of you can easily consult with a physician who understands documentation and coding when you need them? Outsourcing or accessing physician advisors through a third party may be an opportunity for your team to have that at their fingertips as a resource. Is training better handled by somebody who specializes in training? You know, there are a lot of companies out there that provide very affordable options for training, and so trying to develop something in-house may not be the most cost-effective way to do that. How do you get access to technology? Again, one of my challenges at that time, if you don't have the budgeted dollars to purchase that software, how can you partner possibly with a vendor and use their technology out of your operating budget to make you more successful? And then auditing of your coding and CDI programs. How well are you performing? Where are your opportunities for improvement? Using external unbiased resources for this function can result in many times much better outcomes. And once your program's in motion, depending on the model and the vision adopted by your CDI team, some items worthy of monitoring might be your cases per hour. I know here I'm citing a 25 cases reviewed per day. That's cited a lot of discussion at times because many hospitals will say that that seems high. And to truly establish benchmarks for your program, you have to consider what you're asking your staff to do. Each program is different, and the acuity level of the patients are different. If your team is divided by specialty, then the metrics may be different from one team member to another. The physical location, can it all be done from a computer? Do they have to go to the floor and move around? Are they remote and they don't even have to work in the building? They don't have to go to meetings. They don't have to be pulled for other things so they can concentrate all day long on these reviews. What type of technology do they have to support their workflow? There are just a lot of different elements that would make a difference in what that productivity level might be. Average cost per chart reviewed might be something you would want to look at. Your CC and MCC capture rate, your SOI and ROM results, average increase in revenue per chart reviewed, and the denial rate for medical necessity and coding. Measuring your outpatient programs, it's still in its infancy. We're not seeing a lot of criteria being published yet, but some of the things, depending on your vision, you might look at the cases per hour, your OPPS assignments, your booked versus actual procedures, HCCs, and discharge plan compliance. Patients move really quickly through those areas, so it's really challenging to impact documentation real time, like we discussed earlier. So looking at those measures, I think you have to start and get some data and then possibly revise those once you get into the program. Stay close to the literature. I'm sure we're going to see a lot more published by those pioneers in this area over the next 12 months. And as we wrap up today, one of the biggest takeaways I think for us to remember is that as you face challenges that come along with the evolution of the CDI programs, whether they be inpatient or outpatient, it's just really, really important to remember to stay focused on your vision, which we discussed earlier in the presentation today, at all times. That's going to help you eliminate fragmentation of your program, it's going to eliminate scope creep, it's going to assure success of your CDI program and assure the financial success for your hospital. Are there any questions? Well, if there are no questions today, thank you very much for allowing me to participate. I enjoyed having this opportunity. Tom's information and contact information is here on the screen, and I'm sure that he can also connect you with me if you have additional questions after the close of the presentation today.
And thank you very much, Martha. We appreciate the presentation today. I have unmuted everybody. If you guys do have any questions, if you've got yourself muted, feel free to unmute and share, or you can share via chat, or like Martha said, send questions our way. We'll be happy to get them out there and get them answered for you. But if you do have any questions, now's a great time to do it.
So I would be very interested to know how many people on the call today actually have outpatient CDI programs in development or already in progress at their hospitals.
Is anybody on the call got that going on? I mean, I know that we have a CDI program here at US Health, but I do believe it's focused mostly on the inpatient side.
This is Denise from Behavioral Health. Hello.
Hey.
We have a CDI program here at TMH, but it's also inpatient.
Well, we certainly see that, like I said earlier, the outpatient CDI programs are really in their infancy, and there's so much to learn about them. And so I'm sure there'll be a lot of missteps, but I encourage you to stay close to the literature. With the changes in reimbursement, I think we're all going to be forced into that arena, and your expertise as HIM professional is really going to be key to making sure those programs are developed properly. Like I said, I know that when I was in the hospital, some of the biggest challenges were the other departments not understanding coding guidelines and rules. And they believed that you could just remove a diagnosis from a chart. You just didn't have to code that one. Or they would want you to select one that didn't have that particular digit associated with it, or possibly not claiming it as a complication because they didn't really see it as a complication, but it might meet the criteria for a complication. There are so many things that other people in the organization need to learn from you for them to be able to understand their outcomes and know really when they have a safety issue or really when they have a quality issue or a documentation issue or a coding issue. I know our goal for all of us is to provide quality patient care and be reimbursed properly for the services that we provide. It just becomes more complicated every year.
Well, thank you for that. Anybody else had got any comments or questions? Okay, well, on that note, let's give you guys a few minutes back of your day. Thank you for joining us today. Martha and Tom, both we appreciate your participation with this. And to all the callers on the call, if you have called in and you are calling in via phone, make sure you let me know so that, as you see on here, 4 different callers, caller 4, 5, 6, and 7. I believe I've gotten a couple emails from you guys to let me know who you are. But we'll go ahead and end the call. And thanks so much. You guys check out FairCode and get a chance to meet both Tom and Martha. They're great people. I enjoyed speaking with them at the convention this summer. Everybody have a wonderful Thursday afternoon, and thank you again.
Thanks, Jerry. Thanks, Martha.
Bye.
Bye-bye.